All right, we're here at the AATS Mitral Conclave 2017. I'm joined by Michael Borger. Michael, you have the unique, I think the unique experience of practicing in both the United States and Europe as a surgeon. Obviously, you've traveled worldwide. You have made tremendous contributions. What do you see the differences in the sort of the approach to mitral valve disease and even tricuspid disease between the two, Europe and the United States?
Well, there's more similarities than there are differences, but some of the big differences are, for example, especially in Germany, the proportion of patients that undergo a minimal invasive mini thoracotomy approach to the mitral valve is higher than it is in the United States. It's over 50% there, and that's thanks in large part to the legacy of Fred Moore.
Right,
and in the United States, it's around about 15%, although it is slowly increasing. I also find that the repair rate and replacement rate is about similar in both countries. But with regard to concomitant tricuspid valve operation, tricuspid valve surgery, it was a little more aggressive in Germany, a little higher proportion of patients than here in America. Although I know in America it's very regional. Some centers do a very high proportion of it, some centers a very low proportion. And certainly I'm of the thought as well that you should err on doing more of them for patients with a large tricuspid annulus, for example.
So the similarities are what? I mean, the similarities are at least in the high centers, are really really trying to have the best surgical outcomes you possibly can.
Definitely. Another big similarity is something that always surprises me. I've operated in many countries around the world, is that you can walk into basically any cardiac surgery operating room in almost any country in the world, and you will immediately recognize 95% of what's being done and what instruments are being used.
Interesting.
And when you operate in these other countries, you just need to know the names of a couple of the instruments, and it's amazing how similar it is across the different countries. Certainly in the United States, there's of course a higher proportion of disposable equipment than in some of the other countries and less developed countries, but it never astonishes me how much similarity there is. In the United States, patient safety, I think, is a little bit more in the forefront of the surgeon's thinking, possibly because of a little bit more of a litigious environment here. Whereas in Europe, the surgeons tend to be thinking more about what could be the long-term consequences of what they're doing for that patient, and maybe a little bit less defensive in their strategy, and maybe that's why they've been a little bit quicker to adopt these minimal invasive techniques.
Let me ask you from a cardiologic standpoint. It's been my contention in both really in mitral and aortic disease that although it's improving, that the cardiologists have been very slow to send patients to operative intervention, especially the quotes asymptomatic patients. I don't know whether that's been your experience, but did you have that feeling in Europe, in Germany, or is that just my perception?
It's similar to the United States in that it's very personal. So there were cardiologists that were very up to date and strong believers in intervening early in the pathologic process. And there were other cardiologists, in general, the older ones that weren't as close in touch with an academic environment, that were much more conservative in their referrals.
Do you see, in the United States, I see a lot of consumers who are becoming knowledgeable from websites, social media, et cetera, about, gee, you mean you don't have to open my chest to operate on me? They're very attuned to that. Do you see that happening in Europe and Germany?
It's not to the extent that it is in the United States. There's no doubt about it. I'd say probably over half of my patients here in New York would come in and they would, say, "Oh, gee, you look different than you do on Google." They knew everything about you. They know all about you. In Germany, they're a little bit behind, but that's only a matter of time. Although cardiac surgery patients tend to be a bit older and maybe not all that internet savvy, it's their children that are doing the research for them, and that's why I think a good informative educational internet presence is very beneficial for both the patients and the surgeons.
I think it's very important. If you don't do that in today's media, with social media, it's a mistake. Michael, let me ask you, because you've had certainly the experience of It's fantastic training, and then a chance to run programs like this and do everything. Where are we going to be, and what's your future? Where are we going to be in 10, 15 years in the mitral space?
Yeah, I've worked with some of the giants, Tyrone David, Fred Moore, Marty Leon, Craig Smith, and really in Colombia, I really got a good exposure working with Marty Leon, seeing where we are heading in the future. And there's no doubt about it. We're going to be doing more and more percutaneous procedures. Eventually, I think even the degenerative mitral valve patients, we're going to come up with a feasible and effective solution where you could resuspend the prolapsing segment with some sort of Gore-Tex cord plus an annuloplasty procedure. I see that being done. It's already been done a couple of times in Germany, and I see that maybe 5 years down the road becoming a much more common procedure.
Do you not worry, I'm sounding like an old man, which I am, do you worry about durability?
Of course, we're going to have to wait and see what the durability is,
Right.
but I think if we logically extend from our experience from mitral valve repair surgery, if you got a good repair with a very little or no regurgitation at the end of the procedure, it should be a durable repair, as long as you got good coaptation.
Right.
And with the neocord procedure, as opposed to resecting prolapsing tissue, at the end, when you pull down that prolapsing segment without resecting, you have a heck of a lot of coaptation, and I think that that's going to be a very durable repair.
If you're a bull on transcatheter therapies, transapical's going to eventually get to a lesser and lesser role?
Depends. So we already have these transapical neocord procedures that we're doing very successfully. But those are degenerative MR patients which are younger and more healthy, and they can withstand a small thoracotomy. It's not an issue. The transapical procedures for mitral valve replacement, the FMR, the high-risk elderly patients, that's just a phase. It's all going to be transeptal in the not-so-distant future, because you just can't make that thoracotomy on those older, high-risk patients.
Final question, you're now going to be chief of cardiac surgery. Again, congratulations. How do you train the surgeon of the future? What's that training going to be about?
It's not easy, because for them they see that the whole specialty is in a state of flux, and they want to know what should they be preparing for in the future. And I think for them it's very important that they get some wire skills, because minimal invasive procedures are going to definitely require some wire skills.
Right.
I think they need to have more exposure to the cardiology, interventional cardiology world, maybe a few months. But they also have to get comfortable with working with simulators. The problem is that there's going to be less and less straightforward, easy cases for the residents to be doing in their training, and then all of a sudden they're going to finish their training, and the first case that walks in is going to be a type A dissection or a double valve endocarditis case. And therefore, we're going to have to develop ultra-high fidelity simulators in the future so that we can get surgeons that are well trained right from day one.
That's very interesting. Nobody said that. That's a great thought. I think that's true. Listen, you've made tremendous contributions in your career, and we're looking forward to the future. I think going to be just as bright as your past. So that's great. Thank you for joining us.
Thanks, Randy.
Okay.
It's my pleasure.
Super. And thank you for watching. Come back and join us soon.